Good evening, everybody. Thank you so much for joining us. This is Jennie Joseph, and this is another Google Hangout on behalf of the National Perinatal Task Force. I am thrilled that you're on board with us, and just want to make sure that you understand that this is new technology for us. We're having a lot of fun with it, but it doesn't mean we actually know how to work it. So I want to have you take note of a phone number that we will use as a backup in case something goes wrong with the technical side. And you can see that phone number in the Google Plus chat box if you're on Google Plus. If not, we will say the number out loud. In fact, hold on a second for me and I'll make sure that you can get this written down. Okay, actually I can't see it right this second, but I will get it up for you as soon as I can. We'll say it out loud a couple of times so you can make a note of it. So I would like to introduce the women that we have on the panel today so that you can know who's here and we can get started with our conversation. Thank you again for joining us. My name is Jennie Joseph. I'm joined today by Cynthia Jackson, and Cynthia is a certified professional midwife and a doula in Detroit, Michigan. I'm also joined by Jennifer Thedford, who is also a doula in Detroit, Michigan, and then Kathy Bradley, who is my partner in crime, the Director of Perinatal Education for Commonsense Childbirth, which is our organization, and she was on the last Hangout with me, and typically you'll find us joined at the hip. So thank you, ladies, for coming on board, and I'd like to get started because the theme of tonight's Hangout is, what is a perinatal safe spot? So I introduced the idea to you guys last time, and we want to extrapolate on that today. We want to talk a little bit more about that. So I'm going to go ahead and have Cynthia go first. And Cynthia, tell us a little bit about yourself, what you do, why you do it, what's going on, and share more about your story.
Okay, well, my name is Cynthia Jackson, and I'm here in Detroit as a doula and childbirth educator and student home birth midwife. And I do what I do, first, because I love it, but two, my city needs sisters like me on board to help us. Unfortunately, we have one of the highest infant mortality rates in the country, and so I feel like it is part of my job to give back to my own community that helped to raise me. And so it is a lot of work to be done, but I'm doing the best that I can do with the help that I have around me.
Excellent. Jennifer, go ahead and introduce yourself so the audience knows what you're doing and why and how even. Let's hear from you.
Yes, my name is Jennifer Thetford, and I actually live outside of the city of Detroit. Most of my doula work is based, however, in Detroit. I'm helping women in shelters and other various communities with their prenatal postpartum care as well as their birth. I do what I do based on my own personal birth experiences, some of which I wasn't very pleased with, but based on my level of education or lack thereof. So what I'm doing is giving women what I did not have.
Right. Well, I think it's really worth saying that, and for those of you that are listening, to get a real good understanding of why we're even feeling there's a need for such a thing as a national perinatal task force. We know historically that there's been problems within certain communities as far as birth outcomes. Most of us in the work that we're doing are dealing with that on a daily basis. Many of us don't know what to do about it, even if we wanted to do something about it. And so I wanted to bring together people who are on the ground already actively doing something about it. When I say it's a matter of life and death, I'm not trying to be dramatic. I'm not trying to make it seem like more than it is. I've just got to that point, as many of you have as well, where we're sick and tired of this being the status quo. In 25 years in this country, it hasn't changed, and in many instances, it's worsened. So women come into this work sometimes from that place of that's a calling that has been put on their heart and their spirit, and they just come forward. Others come into it because they've been recipients of that kind of care and their experience was less than stellar. Others recognize the dire straits that we're all in and have come to this work to do something about the situation. But I think I'm not wrong in saying that decades later, as we've become to realize what's wrong, we haven't made any real impact on it, not in any massive way. But slowly and surely, individual by individual, we are seeing some changes. And so the Perinatal Task Force is set up to support the people who want to see those changes, to have you not feel as frustrated or overwhelmed or alone as you might have been feeling up to this point, and to say if we band together like-minded folk, we are probably going to be able to make some substantial difference. So Kathy joined in with me, some 20 years ago, I would say, and she will say that, within the last 5 years, she really has begun to get this problem and understand it. But why it's important for women like Kathy to understand it is because we all realize that every one of us together can bring something to the table. But I think it's important to keep stressing that it's imperative that you bring the right things to the table. So, Jen, you mentioned something that triggered this little diatribe here that I'm running in along with, and that is that you said you yourself received a certain type of care from lack of knowledge. Can you expand a little bit about that? Can you talk to us about what you mean when you say you were a recipient and you didn't know, you weren't aware of certain things? Oh, hold on, Jen. For some reason, I don't hear you.
Sorry about that.
Okay.
Well, as far as breastfeeding, not seeing it in my community, I remember going for my first prenatal visits and getting the diaper bags, getting the formula. I'm not getting any education as far as breastfeeding, what to expect. With my first birth, I remember going in and they said that my amniotic fluid was low, and they sent me off into a C-section. And it wasn't until later, actually, that I was doing the doula work and actually talking to Cynthia that you could go home and drink enough water to restore those amniotic fluid levels. Just the lies and just the communication about it all, that did lead me into 2 unnecessary cesareans where there really was no emergency.
Well, and you see, this is one thing. There's so many levels here. One of which is that as a young mother, you were not empowered, you didn't have the knowledge, and you couldn't speak up for yourself without the support. You were also, as a young mother, able to find someone to support you in that you had Cynthia. But more importantly, we have to make the connection between the C-section and the level of risk that you were subsequently put into, maybe as an effort to perhaps protect you and your baby from what might be considered medically an emergency. And that's debatable, and that's not what we're here to do. We can't parse right down to, well, was the physician right or was the physician wrong? What we can say is that we know the evidence is clear. The cesarean section in and of itself is a risk to you as a woman, and even more of a risk to women who may not be in the best of health or may not have the best resources for the fullest recovery, for the most support, and that makes a big difference between your relationship with your newborn, your breastfeeding success, on and on. Like the level that the C-section has and impeding your best beginning as a new mom, building a new family, that is so serious, yet has sort of been swept under the table. Any woman of any race, of any socioeconomic status, physically having surgery to have a baby is a risk. And so there's so many various levels here. I want to bring Cynthia in though, Cynthia, because you're talking to a lot of women who are facing the kinds of issues that Jen has described. And tell me, from your perspective, what are you up against as far as trying to get this work done in a city such as Detroit?
Well, number one is Detroit is actually very big. That's one. Two is that there are lots of I would say factors that are preventing women from getting the help that they need. So we have lots of neighborhoods that are unsafe We have women who can't get to their prenatal appointment because they don't have vehicles and our transportation system is not the greatest. We have women who just don't trust people in general, so they're not going to really want to have someone to come in to care for them for support. Lack of education is definitely one. We don't have a lot of birth fairs that are going on that are trying to educate the community. We have had a few, but the turnout has not really been the best unless, of course, we're giving out something free. So it's just hard to kind of do some of the work without having a major organization backing you up.
Right. Well, that brings me to a question that we've been asked since the launch of the Perinatal Task Force, and that is, who can start a Perinatal Safe Spot? Do you need to have funding? Do you need to have an organization? Do you have to even have credentials? What do you say to that, Kathy, as far as those kinds of questions that are coming in?
About what am I getting questions about that, or?
How do you, how we've been responding to these kinds of questions when people ask, well, do I have to have credentials? Do I have to have funding? I don't have a grant. I don't belong to an organization. Can I start a Perinatal Safe Spot?
Oh, yes, and our answer is absolutely. What we're looking for is for people that, first of all, like you identified earlier, that have a heart for the work that's involved, compassion and care. What's interesting is the work that you do, Jennie, and that I do, and that people that are involved at a level, when you have heart and soul in what you do, you do tend to get a little bit better outcomes. So just just someone knowing that someone cares about them is impressive. We're not looking for people to have all these credentials. We're looking for somebody to know there's a problem and have a little bit of training and guidance on how to better serve and help people get connected.
Okay, and I think it's important to say that the reason, again, I'm stressing this, the reason I started the network in the first place, and I want it national because these issues are legion across our country. The reason I started this is so that those people who do want to make a difference have a support team, have a place, have a network. So sort of it will organically come down to, yes, after, this body of people who are on the ground trying to get work done, it will trickle down in that the recipients of the care will notice the difference from how we approach it. So I'm not trying to suggest that other agencies and other systems aren't trying to attack this problem, aren't trying to deal with this problem, but having seen decades of lack of change, same old story, we're doing another meeting, we're having another conference, we're doing some more research, we need more data. I'm a little frustrated with that. I want to see that we actually get some things done. I want us to have some practical steps, practical ways, doable, achievable goals, and then we support each other while we're getting there so that we can be sustained and so that we can make the difference that we want to. Let me throw this out. Let's just say, for example, at this point there are 100 people that have signed up for the National Perinatal Task Force and are now, officially saying, I would like to be in this task force. And then there's untold numbers of people who are following through on Facebook or trying to connect with us on Twitter. And I'm sure we'll see more social media as we go along. But the bottom line here is that if we, let's just say, of 100 people that are interested in figuring out how to do something practical and achievable, that one woman, one mother-baby pair has the perfect outcome, the best possible outcome for them, that mother takes the baby all the way to the full term, that mother is empowered and ready to go when her labor begins, that she really truly has a choice of where she's going to deliver this baby, and she feels like she can ask questions around her safety and her autonomy when she's laboring. And that same mother comes out the other end with a decision to breastfeed if that's going to work for her, because she happened to be able to get some skin-to-skin time with her baby, that she left that hospital environment or that birth center feeling ready to continue to breastfeed. She understands what to do, and she feels fully supported. Let's just say, just one. So if every one of the 100 women or men that we know who've identified themselves as being interested in being in this task force and interested in seeing some outcomes change, we're able to impact just one woman, think how powerful that would be. That's just 100 women around this country. And it may seem like small potatoes given the amount of people that are having babies in this country, and of course the amount of people that are in jeopardy having those babies. And yet, currently, in the absence of that, those 100 women are still in jeopardy. And that's how important it is. So I'm not suggesting for a minute that we keep this on a small scale. I'd like to see it expand. But I'm not looking for anybody who wants to be involved in this work having to feel pressured or overwhelmed, or that they need a whole slew of money, or they better struggle through and get a grant before they get started. I want to encourage you to get started right away, because you could surely impact one woman right now. Now, I want to speak a little bit more about how you get started, and I want to speak a little bit more about how you impact that woman. So I'm going to go back to Jen. Jen, explain to me what was the one thing that got you active when you were thinking about it. Obviously, you liked the idea of it. You had your own experiences to build on. But what got you started? Where was it that turning point where suddenly you were up and running? Can you talk to us about that?
You mean up and running as far as helping women, or making the decision to help women?
Making the decision. What was it that got you from point thinking about it to now I'm going?
I really don't think there's time to really think about it. In my training through Focus Hope was when I really saw and understand a lot of things I didn't even know had taken place, or didn't know that they affected me in such a way that they did. So just in that initial knowledge, I wanted to start helping women, and I did.
How did you start? What did you do first?
What did I do first? What did I do first? I think actually Cynthia kind of coupled up with me with a mom in a shelter, and from then on, that's just how it got started. So she was the connection, like a direct connection for me with an actual mom in need.
Okay. Cynthia, can you talk a bit about that, how you helped her, but then I'd also like to hear how you got to that point yourself of being in action about what you wanted to do.
Yes, I got started, again, it's from just doula's training and then just going back and doing my own research, but I was also a part of something called Doula's Care, which was it was 10 years ago when this program existed, and it was for low-income women. And so from experiencing helping those ladies, I felt that there was more that needed to be done. Unfortunately, that program is no longer. So there's not something there that we can help the young ladies, but I still was a part of birth fair. There was something called Ask the Doula, Ask the Midwife. And so I had a table there, and I just would go and talk to ladies that were pregnant. I'd get to know them a little bit more, ask them if they needed labor support or any resources in the community that I can help them with. And from that, I literally developed a list of women who needed support. And that's how I got Jennifer on board, because I knew she wanted to have experience in working with women in the Detroit area. So we would go together and help some of the ladies at the shelter, and Jennifer ended up helping, I think, 2 or 3 additional women just from the one person in the shelter who was really pleased with her work.
And one is pregnant again, and I'm going to be helping her soon, too. So.
Well, you're connected to her, and, you know, these are the kinds of connections that, although this is very intangible work, these connections are the building of relationship, which, although all of us would like to earn a living doing this work, all of us would like to feel secure financially doing this work, at the end of the day, we're fed by the relationships alone. Like, those relationships are powerful. Tease out a little bit here how, yes, the one-on-one is the ultimate for us in the birth world. Us birthy people, we want to connect and we want to be with the women. And we get the feedback, we get the reward of their gratefulness, their, you know, speaking to how we helped. All of that is great. But again, let me bring you back to the reality. What we're talking about here is life and death. We want to get to the best possible health for the mother and baby that's possible inside of her situation, and we want to be able to be really cognizant of how that looks for her. So please don't get me wrong. Any of you people that are listening who aren't doulas, well, who aren't midwives, who aren't even necessarily in the birth work field right now, it's about the relationship and the support. It doesn't matter if at the end of the day, the woman chooses a hospital birth versus a home birth. It doesn't matter if she chooses not to wear her baby, she wants to put the baby in the stroller. It doesn't matter if she doesn't want a cloth diaper. These things are not what we're talking about here. The relationship of meeting her where she is and understanding that is valuable in terms of her feeling supported. So that's the first thing. But the second thing here, and I think Jennifer and Cynthia really illustrate that, Jennifer's support came from Cynthia. The second piece, which is not something we don't talk about a lot in this work, is that the support is needed for the providers too. The support for each other, someone to hold your hand and get you started, someone to sort of ease you into the work, remembering that the ultimate goal is however we can best do that to help this mother and her family be more secure, be safer, be healthier, is how we need to address this. So this is completely different to the usual birthy helper lady. Okay? This is different to, well, I've done my doula training, so now I'm able to do it. You don't need any training to care. You don't need any training to create a relationship. You don't need any training to be a human being. This is the difference to what I'm trying to talk about inside of this perinatal task force. That this is not about the usual players, the usual ways. There are many task forces around this country, many public health works going on where people are trying to understand the problem and address the problem. Many programs being developed, many grants being written. We should never stop that. But I think that we can make a better difference, a quicker difference, a more practical difference. Even if it's slower, even if it's just one-on-one, we can make that difference for the outcome by realizing where the areas of support are needed. So just to reiterate, the purpose of the Perinatal Safe Spot is to create the access point. So in the case of the clients, the women who are having these outcomes, they don't have an access point unless we show up in one way or another to provide that. Okay? So I'm not just talking about access to the prenatal clinic or access to the physician or even access to the hospital. I'm talking about access to what we want to offer them, the support that they can't seem to find anywhere else. That's what we need to consider. How do we give access? So Jen, as a fledgling doula, you needed access to an experienced doula to hold your hand, to invite you in and to support you. Cynthia, as a student midwife, you need access to senior midwives to help support you while you finish your training and hold your hand and get you to where you're going. Midwives, we need access to collaborative care so that we can then provide the safest, healthiest care for women who are needing or choosing midwifery services. Physicians, you need access to understand the importance of cultural competency in how you deliver your services. Being in a building does not connote safety. These are the layers that we have to contend with in our perinatal structure in the United States. And I'm saying that at every entry point, we can provide access if we're very thoughtful and purposeful and are strategic in how we do what we're trying to do here, because we are trying to dismantle a very broken system. And I suggest that it's doable. I think we can achieve that. I think you guys get that we can achieve that. And I want us to troubleshoot ways to get that done. Okay, so let's go back to some of the questions. And by the way, if you have questions, please type them into the Facebook page. The National Perinatal Task Force page is on Facebook. You can search it and you'll find it. We also have Twitter, which is at perinatal, and then TSKFCE. TSKFCE. So the word Perinatal Task Force is not spelled out completely. Perinatal, T like Tommy, S like Sam, K, F like Frank, CE. Okay, at Perinatal Task Force. Okay, so if you have questions, please type them in, and we'll try to get some of your questions on the air. I would like to address again some of the questions that we've already been asked. As Kathy was saying, people are asking, do I need to be credentialed? No, you don't. Do I need to have money? I don't think so. It would be nice, and I would like to see how we could, as a group, begin to form ways of finding money, finding sponsorship, finding supporters, creating ways to fundraise. That's great. We'd like to do that, but I'm not waiting for that. That's what I'm asking you. Are you ready to go forward with us without the money? We want the money. It'll come. But right now, we can't hang around. How many more women should be in jeopardy? How many more babies shall we lose while we're sitting around waiting on the money? It would be awesome if people would just knock the door down and say, here, we've got funding for you, but that's not the case. Okay, other questions that we're getting asked is, well, or a sticker, or what do I do to connote that I am a member of this perinatal task force? Well, I would like to do that on an individual basis. I would like you to contact us if you're interested in being a safe spot, and let us know why and what you're doing, where you are, and how things are going already. And between us, we can work it out so that we can get you up and running as a designated safe spot. It's not going to cost you money to be a safe spot. You don't have to go making it complicated, but there's certain criteria. One, of course, which would be that you're serving women who are in a materno-toxic zone. That's the whole purpose of what we're doing. So if you're not in a materno-toxic zone yourself, or you're not willing to serve in a materno-toxic zone, then you could also consider being a virtual perinatal safe spot by managing maybe one-on-one with a couple of women or a group of women via the text or via our portal that we have developed. But as a perinatal safe spot owner, if you will, or designee, you would have some access to some further tools. So I'd like to do that with you on a one-on-one so that we can make sure that everybody gets what they need to be supported to be a perinatal safe spot. Now I'm going to flip it. If you're not ready, if you don't think you're up for it, if you don't understand it well enough yet, don't be a perinatal safe spot. That's okay. Hold on. If you want to hang with us and keep learning and we'll keep troubleshooting, we'll keep it going till you feel ready and confident. But you don't have to be a perinatal safe spot to be a member of the National Perinatal Task Force. What you do have to do, if you don't mind, is commit that at least one person per year. I would like to find out how I personally, one person, can impact one other woman to the point of her having a better chance for a better outcome for herself or her baby. That's all I'm asking. You might say, well, I could commit to doing that for 10 women, or I could do that for 100 women, or where I work, I have access to 1,000. Doesn't matter. But at least one other woman could be impacted in this country by your commitment to being there for her in a way that will get her and her baby a better chance than she has right now if you don't do that thing. That thing could be, I'm going to be in text and I'm going to write emails to my congressman. I'm going to be the one who goes to that next Healthy Start board meeting as a consumer. I'm going to sit on the fetal infant mortality review board as a practitioner. Whatever it is, I'm sorry, please, we're hearing an echo. I'm hearing an echo. But I'll keep going. Whatever it is that you can do for one person at a minimum, I want you to think carefully about that. And it doesn't mean that you have to become a designated safe spot, but it really helps if every one of us who's in this task force starts thinking that way. So Kathy, can you help me, because I want you to talk about some of the women that we hear from are quite removed from materno-toxic zones, whether it's geographically, whether it's socioeconomically, whether it's race, whatever is the reason, they're not a member of, nor will they ever be a member of, or have to contend with living in a materno-toxic zone, but they want to help. Let's talk a little bit about how that looks for those types of women, or men.
Right. Well, and I'm case in point. I worked at a hospital which is now the largest volume delivery hospital in the United States, downtown Orlando. I worked there for 14 years. And as you mentioned at the beginning, it wasn't until just about 5 years ago, and we'd worked side by side. I was your birth assistant well before the birth center ever even existed.
Yes.
I considered myself very involved in the pulse of birth. I was very connected to people on a national level. And yet, somehow, I missed what was actually going on, especially in the African American community. I had no idea that babies were dying at twice the rate, that women were dying, I mean, in childbirth or the postpartum period. And when I finally, came to that realization, it was very hard to swallow that reality even existed. I think sometimes for those of us who are not working in those areas, there's a certain level of denial that we have to deal with. We have to really, we don't want to believe that our country is still a very racist country, because we've desegregated and we've done this, but yet the reality, and it exists. And Jennie, you and I know, you and I've had some very in-depth soul-to-soul conversations, that, I've been in tears, you've been in tears about the reality of what's really facing moms and babies. And like you said, there's the birthing community. I mean, as far as, it's great to be able to teach moms different birth positions, to teach moms how to be hands and knees, to teach about different options. But when what's facing that woman does she even know how to get to the hospital? Does she have a way to the hospital? We can tout breastfeeding till we're blue in the face. What are her resources? What is she facing when she even comes home? It kind of really brings everything down a little bit more, the reality of the care. So for people that may never work in that area, where I feel I can help is educating people that the problem exists. I mean, look how many years I was a certified childbirth educator. I was a certified doula. I was an internationally board certified lactation consultant, yet I had no idea that the numbers were like they were. Rather embarrassing, but yet I guess it's part of my journey to really how prominent this problem is. I mean, what more? I mean, I could expect somebody who works in finance and banking that, may have had a child that may not have a clue to what the rates look like. But I was in the field. I mean, and not only that, working next to a woman who, I mean, Jennie, let's say it, you are a forefront runner in this. You are saying, America, we've got to wake up. This is wrong. This is not right. And I've known you for that many years. I mean, even how more just amazing is it that I worked alongside of you, and yet I had no clue. Did I just have blinders up? Was it just that you had your head down and you were just trying to do the work, and not trying, you are doing the work, and just meeting the women and getting and doing? I mean, I've pondered that many times, like, how did that happen? So if it has happened to me, I mean, here I am, how many countless thousands of other people out there, how many other birth workers of, the white race, if you will, that have no clue to really what is going on. And that's, so when people think of, okay, I may not be able to work, or I don't have access, or maybe it's not my place to work in this zip code that is, there. I can still be a sentinel. I can still say, and I can't tell you how many times, I am somewhere doing something, and because I am a true birth junkie, I will come up with a way that, lets people know that there is a problem, that we truly have maternal toxic zones. And we're a little in denial, I think, in the U.S., that even the U.S. as a whole, when you compare us to other countries, when we rank 60th, I'm sorry, but we're a maternally toxic country. I mean, that kind of hurts at the heart level. We're a little prideful here in the U.S. We have the best maternity care. We have this. We have this. Well, I'm sorry, statistics don't lie. Time and year after year. So we have, in essence, become a maternally toxic country. And even more, in globally, well, I should say nationally, when compared to other countries, we're toxic. And we've got to change it. And